you can actually pass a current through that wire, and then that polyp drops off. And so then you can remove the polyp. Nearly always by doing that, that's all that the patient will need. And then that polyp obviously isn't going to go on to become a cancer like at the top. And then what you see on the left panel, this is what we call virtual colonoscopy. So the other technical term for it is computed tomographic colonography. So it's a special kind of a CT scan. Some of you have probably had CT scans of your abdomens and chests and things. And the difference with a virtual colonoscopy is that the radiologist uses some special computer software to interpret the pictures. But with that special software, you can actually end up with pictures like you see in the top left corner and the bottom left. So that's the same cancer and the same polyp, but the left panels are those lesions seen, as it were, without sticking anything inside of you, but just having a special kind of a CT scan. So that sounds good. Next slide. And again, I don't want to bother you with the numbers here, but when we start checking out the performance characteristics, we use a thing called sensitivity. And sensitivity basically means if you get a positive, if you have the condition, what is the likelihood that you would get a positive test, whatever the test might be that you're using to that. So if you have a lump in your chest, you'd want a chest x-ray procedure that would have 100% sensitivity. That means that every case of that kind of whatever it was in the chest would show up positive. Because you want a test with 100% sensitivity, but you also want to have a test with very good specificity, and specificity is all about, or is really only about making sure that if you do not have the condition, then you have a negative test. So you want 100% sensitivity and 100% specificity, and hardly any tests do that. But all I'm doing here is to put up some numbers that's showing that virtual colonoscopy actually, in terms of diagnosing stuff in the colon and rectum, has much better performance characteristics than the stool blood tests that I already mentioned. Next slide. And again, I'm not going to go through these next two slides in any detail, but again, this is stuff that you as informed members of the lay public, the general public, need to know. And one of the things that we have lots of bodies that come out and issue recommendations for things. And the whole approach, where everybody can agree that everybody should get checked out on a regular basis from the age of 50 or so onwards for colorectal cancer. But there are still unseemly food fights going on about what is the best way to do it. And what we had in 2008 was two separate august bodies coming out with really rather different recommendations. So I'm not going to take you through all of these recommendations, but you know, it's much better that you should know that the experts, close quotes, can't always agree amongst themselves and don't always come up with necessarily uniformly wise advice. But suffice it to say that on the list I mentioned, you can check in there with the flexible sigmoidoscopy or the colonoscopy. Don't worry about DCBE because nobody's doing barium enemas any longer. And then CTC, that's the computed tomographic or the virtual colonoscopy that I just mentioned. So this body is saying you can have any one of those as a regular way to get screened. Let's go on to the next slide. And then later in 2008, the other body came out, and there was a good deal of overlap amongst these recommendations. And this is the United States Preventive Services Task Force. There was there was overall agreement, as you might hope, but there were some very important ways that they didn't agree with each other. And that's getting into the weeds and too much inside baseball. Be happy to discuss it with you afterwards. But again, I think it's important that you be very well educated and you know that we go with the best evidence that we have. And even when we have the best evidence of what we think is the best evidence, then people can differ among themselves. Anyway, next slide. So this is, I boiled this down. So if you take all of those recommendations, and there will be people who would disagree with me, but to make it relatively straightforward and simple, number one, everybody aged 50 and older should be getting screened for colorectal cancer on a regular basis. If you have access to colonoscopy, then most people would agree that that's probably the best test. There's controversy about what I put second here, but I think if you can't get a colonoscopy, then get a virtual colonoscopy. And then if you can't get either of those, then you should have a stool blood test. So, you know, that's not everybody would agree with that kind of ranking. But one of the problems with colorectal pellet, I won't ask questions, but I'll throw out a few trivial pursuits sorts of things. So you're all, I think, aware of the importance of getting screened for cervical cancer. We still have a long way to go, but at least it's generally agreed, and the information is out there that everybody should be getting screened for cervical cancer. And even in those most hard-pressed communities, 80 to 85% of women are getting screened for cervical cancer, having pap smears. Mammography rates are up. You know, the common people will just, you know, put me right with the numbers, but you know, 60, 70, that kind of range. For colorectal cancer, there is no, apart from the most affluent and privileged upper middle, socioeconomically advantaged people, upper middle class people, they're the only ones that are getting colon cancer screening rates above 50%. And in many populations, many parts of the country, and again, there are food fights about agreeing or not agreeing with the numbers. The ways that these numbers are gathered are quite suspect in some ways. There are many populations where if 30% of the population are getting screened for colorectal cancer, then that's good. So we've got a long way to go, and I think a major part of the problem is that the message is complicated, and so people are told you can have a stool blood test, or you can have a colonoscopy, or you can have a sigmoidoscopy, and at the end of the day they throw up their arms in horror and say, well, you know, how do I decide? So we've got to make it easier and more straightforward. We've got to do a better job. Next slide. And so I'm just going to finish up with a project that we've launched here on Navajo, and Dr. David Downing, the clinical director at Fort Defiance, is here, and he's one of the major collaborators in this project. We're doing this with Fort Defiance and Tuba City, and there are, I was talking to somebody yesterday, there are the most widely used and inexpensive of the screening tests, one or other of these stool blood tests. Well, it's very difficult to do that stool blood testing here on the reservation. The plumbing circumstances aren't always optimal in the homes, and many people, you don't need me to tell you this, many people don't have regular access to US mail. So the rates for doing the stool blood test are abysmal, and it probably isn't going to get better. There are some wonderful physicians at all of the Indian Health Service hospitals, but there aren't enough physicians at those hospitals doing colonoscopy to be able to provide colonoscopy screening to everybody who's here. I love going to somewhere like Phoenix or Chicago and saying, how many gastroenterologists are there on the Navajo reservation? And the answer is zippo. And you know, as you all know, this is an area the size of West Virginia, over 250,000 people. So Tucson, where I live, population about 1.1 million, so not much more than 4 times population. There are 35 to 40 gastroenterologists in Tucson. So there are some major differences and disparities. Anyway, so virtual colonoscopy is out there. It's being done a lot now, and it's still finding its place. But next slide. Next slide. What we decided to do, because I was told everywhere I went that they're having a lot of trouble getting colon cancer screening. Now you can see here that the places, the stars, the IHS hospitals, and they actually all have CT scanners, which are perfectly good for doing virtual colonoscopy. And then next slide. And then some of you were at a session we had yesterday afternoon talking about telemedicine. This actually is a diagram of